Hello, my name is Dr. Reshma Matani. I'm Chief of Breast Medical Oncology at Miami Cancer Institute. It's my pleasure today to be joined by two expert faculty, and I'll ask them both to introduce themselves. I'll start with you, Dr. Gradishar.
Hi, I'm Dr. Bill Gradishar from Northwestern University in Chicago.
Hello, I'm Joyce O'Shaughnessy, a breast medical oncologist at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas.
So let's dive right in. We have two metastatic breast cancer cases that we'll be discussing this evening. And here's a summary of the first case. This is a 68-year-old female with a history of occult metastatic breast cancer, luminal B, HER2 negative, with lymph node and bone metastases. And she's received treatment in the metastatic setting with palbociclib, letrozole, and bisphosphonate therapy, has experienced progression, and then was treated with fulvestrant. At that point, a repeat biopsy was done that showed a change in the phenotype to triple negative breast cancer. And as such, she received chemotherapy with capecitabine for 12 months with a minor response, and now has progression of disease that is suspected but not proven. The question for our panelists this evening will be with regards to the next treatment recommendation. But first, let's detail the case a bit more. So this patient initially presented with pain, right axillary and supraclavicular adenopathy, and bone metastases, and maintains a good performance status. You see her medical history is unremarkable. Her gynecologic history is as shown. She has no toxic habits and has no family history of breast cancer or other cancer history, and is not of Ashkenazi Jewish ancestry. In terms of laboratory work, blood work is normal. She has normal tumor markers at baseline. Interestingly, despite having palpable right axillary adenopathy, breast imaging shows no evidence of abnormalities as detailed here. Mammography and ultrasound are read as normal, as is a MRI of the breast. Interestingly, again, despite the palpable adenopathy, there is no uptake on the PET scan, but bone metastases are noted on bone scan. A lymph node biopsy confirms that this is breast cancer that's luminal B, so presumably an ER positive tumor, HER2 negative. And on that basis, she receives palliative treatment with palbociclib, letrozole, and bisphosphonate therapy, and achieves a partial response followed by disease progression after 22 months. At that point, fulvestrant is initiated and she responds for approximately 3 months. At this point, the decision is made to repeat a lymph node repeat a biopsy. So a core needle biopsy shows invasive ductal carcinoma, but this time the ER, PR, and HER2 are negative. We don't have any information on the IHC result here, just read as HER2 negative, with a high Ki-67 of 40%. Next generation sequencing shows no identifiable mutations. And at that point, capecitabine is started for 12 months with good tolerance and a minor response. And then at this point, she has disease progression, which is suspected but not proven. So the question for the panelists, which we'll certainly dive into in detail, is with regards to next treatment recommendations as the next therapeutic line of treatment. But before we get to that, let's dissect part of this case and engage with our panelists here. Dr. Gradishar, I'll start by asking you how common it is of a clinical scenario to see a patient like this with de novo metastatic breast cancer, and can you give us some comments on the approach that was taken initially to treat this patient who presented with lymph node and bone metastases without a primary identified in the breast?
Well, no primary at all is a little bit unusual, but not unheard of for people who see breast cancer all the time. Certainly the approach that was taken for a patient who has ER positive metastatic disease was appropriate because we think of CDK4/6 inhibitors as foundational for initial steps in treating such patients. And predictably, the patient sort of got the expected duration of response, roughly 22 months. And thereafter, the endocrine therapy seemingly didn't do a whole lot. and the patient was, the decision was made to switch to capecitabine. I guess one of the questions I have, and of course, with the information we have, we can't answer it, but this idea that she had some progression that was suspected but not proven. I think for most of us, we'd want to get a sense of what that was, because if the patient was responding a little bit and tolerating the therapy well, a consideration would be to continue for a bit with what she's already getting, that is the capecitabine. And, not to monopolize the discussion, but I think going forward, we'd start thinking about alternative antibody drug conjugates in such a patient. And the only thing I'll make one final comment on and leave the rest for Dr. O'Shaughnessy is, there is the possibility that this is a heterogeneous tumor. And that is that, there might have been a mix of clones right from the get-go that responded seemingly well to the endocrine therapy. And now what's left is, more of a dominant triple negative phenotype. The distribution of the disease is still following sort of an endocrine or an estrogen receptor positive type tumor with bone and lymph node involvement. So there's a little bit of, each feature for each phenotype that's present in this cancer. But I'll let Dr. O'Shaughnessy expand on those initial thoughts.
Yeah, I totally agree with you, Dr. Gradishar. And yeah, it's this whole issue of how often the estrogen receptor is lost, or the cell kind of remodels itself, or whether it's a biphenotypic cancer from the get-go with some luminal B admixed with triple negative. I don't think we have a great feeling for that, but I will say just from experience that when patients are getting endocrine therapies, and it may be particularly fulvestrant, where fulvestrant leads to the degradation of the estrogen receptor, that other nuclear hormone receptors, such as the androgen receptor, come up. Now, there's not real clinical utility in checking for the androgen receptor, but I would say that sometimes these cells can remodel themselves back again, and you can have sort of reemergence of the estrogen receptor. So it's something that I would, consider biopsying, and maybe even if she's progressing in her bone, for example, consider biopsying the bone disease and see if the estrogen receptor is there, because there's a number of options. Of course, she could go down if ER reemerge, such as, exemestane everolimus, because she doesn't have other targets. Speaking of targets, triple negative now on the right lymph node core biopsy, and NGS does not identify any actionable mutations, but it'd be worth looking at PD-L1, not likely at all to be positive, but probably reasonable to take a look. And then the other issue that, Dr. Matani alluded to is maybe a little deeper dive onto the definition of HER2 negative. Is there a 1+ there, which is, 10%, more than 10% of cells just with a very faint cytoplasmic membrane staining? Our pathologists really have to understand that it's useful now to distinguish between 0 and a 1+, for example. So we could use additional information there as well, diagnostically.
All great points. Just to kind of make sure the history in terms of what she's received, that we're all on the same page. She had palbo, letrozole, and bisphosphonate therapy for 22 months, fulvestrant for 3 months, and then progressed and was biopsied at that point, and then went on to capecitabine when triple negative disease was identified. I think the choice of biopsying after that 3 months with the fulvestrant therapy after 3 months with progression was an interesting one, because in the setting of fulvestrant monotherapy, there are several trials now that are showing us pretty dismal responses to single agent fulvestrant. So I think it was an interesting choice to repeat the biopsy. But in the situation of second line therapy, it's notable that the NGS testing was done after progression on fulvestrant. Would either of you have been considering doing it earlier to consider perhaps a combination therapy as opposed to single agent fulvestrant?
Sure. And I think that, that could have informed us about a PI3 kinase mutation earlier on. That might have been a consideration with alpelisib. And then of course, there's also newer drugs that are recently approved, including elacestrant. If there was an ESR mutation that was present, may not be available everywhere, but these are things that come into the equation of what's the next best therapy, particularly when this patient seems to have a distribution of disease, as Dr. O'Shaughnessy and I both pointed out, that is sort of consistent with ER positive disease. The biopsy is what it is, it's triple negative, but it does raise the issue of whether there might be, biphenotypic disease present.
Yeah, and I think if when the patient's progressing on palbociclib and AI, that really seems to be a good time to get circulating tumor DNA, which integrates the mutational status for all of the metastatic sites that are, presumably, proliferating and therefore shedding. Not every tumor cell will shed ctDNA, but if they're proliferating and progressing, it's more likely they're shedding DNA. So you can do ctDNA, and post-progression on AI plus CDK4/6, the incidence, for example, of having an ESR1 mutation could be in the 30 to 40% range. And, elacestrant is really just brand new and just not available yet, globally, but it's going to be coming. So yes, I do think post CDK4/6 is a good time to check for ctDNA. I tend to do more ctDNA than biopsies, although I like the tissue too. I like the tissue for the NGS. I like them both to get a feel for what's really going on with this cancer, particularly since it did not respond to the fulvestrant.
So another question is, would either of you consider germline genetic testing despite the lack of family history in this patient with de novo metastatic disease?
Absolutely. So I think that that's an important point, because we often have this assumption that if you're ER positive, the chances of being BRCA positive is fairly low. But numerically, as we all know, there's so many more patients with ER positive disease. The absolute number of patients harboring a mutation is actually numerically higher in that population. So I would rule it out as an option, because this patient could get aliprib or talaziprib as a potential therapeutic intervention if that were present.
And the NCCN, as Dr. Gradishar knows so well, really does recommend germline BRCA1 and 2 testing for all women with metastatic breast cancer that's HER2 negative, because of the studies Dr. Gradishar just mentioned with the talazoprib and the olaparib, the PARP inhibitor. So yeah, great point.
So making sure that we actually address the question that's been posed to us with regards to what would the next treatment recommendation be. Again, post CDK inhibitor and letrozole for 22 months, fulvestrant for 3 months, capecitabine for 12 months, and now with suspected progression. Dr. O'Shaughnessy, maybe we can start with you. What would be your next therapeutic decision?
Well, I think there's room for some choices here and some conversation with the patient, about the various choices and toxicities, because I don't think in this second line setting, which would be a chemotherapy setting, given that we have triple negative breast cancer right now, that there's only one choice. I would take a look at the HER2 status, as I had mentioned before, to see if there is maybe a 1+ there. But even if there was a more of a stronger 2+, but if there's only a small 1+, small percent of cells, 10% or very barely 1+, given that we have relatively limited data with TDXD in triple negative patients that are HER2 low. When it comes to an antibody drug conjugate, my personal choice usually in triple negative breast cancer patients is sacituzumab. Now, sacituzumab was approved by the US FDA and potentially other regulatory authorities around the world for the third line and later setting, unless patients had adjuvant, neoadjuvant chemotherapy and progressed within a year, or per NCCN guidelines, the adjuvant, neoadjuvant can count as a regimen, then just one additional regimen in the metastatic setting, but she's only had one chemotherapy regimen, so she doesn't exactly fit the guideline approval for sacituzumab. You know, in Europe, bevacizumab is used with paclitaxel, and I actually think that would be a very reasonable combination for this patient. I think one could even consider a pegylated liposomal doxorubicin. This patient's had very, very little cytotoxic therapy. And if we say, where are we going to get our survival advantages? There are some data that paclitaxel and bevacizumab in the first line setting, specifically in triple negative breast cancer patients, can improve survival. So I'd probably lean in that direction, provided there was not a contraindication to bevacizumab. But like I said, I think that, you know, conversation could be had around pegylated liposomal doxorubicin, but generally to get the paclitaxel bevacizumab, it needs to be early line, maybe first line, or perhaps there's some flexibility about second line in patients who get capecitabine. So probably if I could, if it would work from a regulatory and funding standpoint, I'd lean towards the paclitaxel bevacizumab, and then my next line would probably be sacituzumab.
And Dr. Gradishar, your thoughts?
Yeah, I don't disagree with Dr. Shaughnessy's reasoning. I think this is an example where, you know, in the US, we may have trouble getting bevacizumab covered in this setting, whereas in Europe, it wouldn't be as big an issue. And similarly, as Dr. Shaughnessy pointed out, because this patient's relatively chemo naive, we may have challenges with sacituzumab govitecan. But that said, if I was saying what I'd really do, you know, I'd probably see if I could get sacituzumab govitecan in lieu of the bevacizumab. I think we probably get it by the insurers easier than perhaps bevacizumab.
Great. So thank you for this great discussion on this very interesting case. So I'll just summarize the recommendations. We have a patient who is 68 years old who presented with de novo metastatic disease to lymph nodes and bone, and had a biopsy that showed ER positive, HER2 negative metastatic breast cancer, received palbociclib, letrozole, and bisphosphonate therapy for 22 months with a partial response, fulvestrant for 3 months, and then had a biopsy that showed a change in the receptors to a triple negative tumor, received capecitabine for 12 months, and is now suspected to be progressing. So the recommendations from our panelists included to recommending that it would be important to confirm that she is indeed developing progression of disease. And if it's not confirmed, to consider a continuation of capecitabine, consider NGS testing, ctDNA testing in the second line to help inform treatment decisions. Germline genetic testing to make sure that she has the opportunity to receive a PARP inhibitor, and post confirmed progression on capecitabine, the recommendations would be to consider bevacizumab and paclitaxel, or perhaps liposomal doxorubicin. And if we could get sacituzumab govitecan approved, that would certainly be an option as well. Thank you.